All right. Welcome, everyone, to this medication talk that we do in the education classes on pain management. And yeah, today we'll be talking about medications. But first off, I like to start with a grounding or a meditation. So if you all wouldn't mind getting comfortable, maybe that's sitting in a seat with your feet on the ground. Maybe it's laying down, whatever works for you in this moment, and close your eyes if that feels safe for you. And start with just taking some slow, deep breaths. And I want you to envision roots that grow from the base of your spine and go down deep, deep into the center of the earth, and envision those roots kind of wrapping around the core of the earth and helping you to feel really grounded and safe. Next, what I want you to do is take 3 quick inhales and then hold that inhale for as long as feels comfortable for you, but you're kind of challenging yourself a little bit. And then really exhale that with an audible sigh. And then let's do that one more time with 3 quick inhales and hold it. And sigh it all out. And this is one type of breathing exercise that has been said to kind of help reset the nervous system in a way and help kind of calm things down. So now let's go ahead and have you open your eyes and we will dive in. So first off, a few quotes that I enjoy that were taught to me by my mentor. So a strong, positive mental attitude will create more miracles than any wonder drug. And that was Patricia Neal. And then second is, it's hard to get enough of something that almost works. So, with pain education, we have been shown that learning how pain truly works in our body is shown to be more effective than any medication that we can offer. And it also gives control back to you on managing your pain. And then also something that I frequently hear in clinic is when we're going over medications with patients, I go one by one down each medication and I ask, what does this medication do for you? And does it cause any side effects? What are the benefits? And I frequently hear, I don't know. I'm just hoping it does something. And so, it's really important not to be chasing after a medication or taking a medication just with the hopes that it's doing something. In pain management, it's usually pretty easy to tell either this is helping or it's not. And to not be taking it if you're just taking it because you're hoping that it's doing something for you. So this also can be really helpful, and it's called letting go. So non-attachment, clinging to the idea that a medication alone will cure your pain will bring only suffering. Clinging to the idea that anything should be different than it is will bring only suffering. And letting go of attachment to things, ideas, and demands brings peace. And this is really something that we see in our clinic, is that patients or people that are able to start living life despite pain instead of putting life on hold until pain is cured or gets to, a certain expectation. practicing non-attachment is where our patients and people get the most success when it comes to living life despite pain. Easier said than done, but definitely something to practice to get the most out of this lifetime. Okay, so now we are going to watch a quick YouTube video called The Drug Cabinet in the Brain, and it is done by one of the leading pain researchers based out of Australia, and it's talking about the natural medicines that we have in our body to help with pain. So I hope you enjoy it.
Hello, my name's David Butler, and I'm going to tell you about a remarkable thing that we all have deep in our brains, a drug cabinet full of the most remarkable pain-killing chemicals. This little cabinet is deep in our brains. This is my picture of the brain here. We'll put a little bit of hair on here just to orientate yourselves. Deep in our brains, we have areas that work together to produce remarkable pain-killing drugs. I'll draw it as a box for you. And we'll put a big cross on it. Now, if I was to ask you to name the painkillers that you can buy from the pharmacy, you'd probably name Nurofen, Panadol, Panadine. You would also be aware that morphine is a powerful painkiller. But can you name the ones that your own brain makes? For example, you can make opioids like endorphins and enkephalins. You can make serotonin. Your brain can even make morphine, and it's a morphine that's much more powerful than mankind can make. And these are made in this remarkable drug cabinet. How does it work? Well, these chemicals are made and they trickle down the spinal cord. They also trickle up into the brain. Let's look at the spinal cord first. If these painkillers are trickling down into the spinal cord, then impulses coming in from the body telling your brain about warmth, cold, stretch, danger can be stopped at the spinal cord. It can stop any impulses coming up. Now that's a great system. That's a great system. So how do we open and how do we close this drug cabinet? Well, the cabinet is under control from various areas up in the brain. And these areas in the brain talk to each other. They weigh up the situation of the world. We say they weigh the world. And they decide if it's worth opening up the drug cabinet. If it's open and the painkillers pour out, there'll be no pain. If it's closed, then impulses can come in and there will be pain. And of course, these areas of brain take their messages from the eyes, from the nose, and from the ears. But the key question the brain has to answer to work out whether it's opening up the drug cabinet is simply, is it worth making pain? Is it worth having pain? Is it worth pain? So let me give you some examples. If you run and stub your toe while crossing the road and you have to get out of the way of the car, it often doesn't hurt. It might hurt when you get to the other side, but the brain's made a decision. It's not worth having pain now. Pain can wait. And what it will do will be simply to float, and there'll be no pain. Or you may have heard of people finishing a sports event with a severe injury, but that person's decided it's important for me to finish this game. And therefore, it's not worth having pain right now. In that example, open up the cabinet, flooded, and impulses get no further than the spinal cord. But it can go the other way too. If you put a pin in a violinist's finger, it hurts more than if you put a pin in a non-violinist's finger. Obviously, there's much more of a threat or a challenge if you put it in a violinist's finger And the brain will think, hey, it's worth having pain here. This needs protection. Let's close the box and have more pain. If you're scared about your back, if you're worried about your back, the x-ray doesn't look too good, somebody has said you're in a bit of trouble, there's a lot of degeneration there, and you don't understand the meaning of pain, then the brain quite rightly would make a decision, it's worth having pain here. Protection is needed. And of course, pain is one of the greatest protective things to make you change behaviour. But I should say, let's be grateful for the man-made drugs too, because at the right time and context they can help, particularly for acute pain or when there's inflammation happening. But the key thing is, for any man-made medication to work, it needs to kick in your own internal pain control system. If I was to sum this up, I'll do it with the key. What is the key to opening up the drug cabinet in the brain, to opening it up and flooding so we don't have pain all the time? Well, it's understanding. It's having support. It's having knowledge. It's having achievable goals. In particular, it's knowledge. We say that knowledge is the greatest pain liberator of all, particularly knowledge of how your body works.
So what did you guys think about that? I always find it very interesting to hear about our own internal medications, so to speak, and how our brain determines whether or not we're going to have pain by whether it senses danger or not. And that also, if you caught at the very end, what's the key to opening up that medicine cabinet within our bodies? And that's learning about, again, how pain works, having the right support, and having achievable goals that you work towards, and several things that you're learning about throughout the other classes in this series, as well as working with the providers within this clinic. All right, so to start out with, the important thing to know is not to chase after the magical pill, so to speak. There's not going to be any one medication that is the cure-all or the fix-all. In the pain world, a medication is brought to market and considered successful if it reduces your pain by 20 to 30%. So again, it may take a few medications from different mechanisms of action, meaning that 2 or 3 medications that work in different ways to lower the pain down in incremental notches to make it more bearable for you. But then it's also utilizing things such as yoga or Tai Chi, or improving sleep, or looking at ways to either reduce stress or cope with stress in a healthier way, and on and on and on, right? It's coming up with a way of living, right, to help you get the most out of reducing your pain, and medications is only a small piece of that. And I often also look at medications as a bridge, right? When you're in a lot of pain, it affects everything, and it can take a lot of energy, and it can be really difficult to have the bandwidth, so to speak, to work on anything else. And so the way I like to use medications is that we use medications for hopefully a short period of time to bring that pain threshold down, to give you this much capacity, right, to put your energy into other things that will help with pain, such as getting more functional, or working with physical therapy, or, whatever it is in your treatment plan. It allows that to be easier for you so that you can make shifts to live healthier. And then hopefully you get to a point where maybe we can reduce the medications down or completely off, because you've implemented all of these other things within your life that have helped reduce pain. The other important thing that I alluded to a little bit ago is with medications, It's always very important to only make one change at a time, especially when we're looking at pain medications, so that you can see what difference did that make in your life. Did it make it easier to be more functional and do more? Or did it not make a difference at all? Did it allow you to get better quality sleep that then allowed you to have an easier time the next day with maybe lower pain levels or increased function? And then what side effects did it cause? And with all of this information, that's how you and the provider that's prescribing for you decide, was this medication worth the potential risks of it because it's offering you so much benefit? Or is it one of those things that you're really just hoping it does something, but you've surpassed, maybe it's a medication that we like to give it 6 weeks to make sure it's working, and you get past that and you haven't really noticed a change. Or it's a medication that should work right away and you tried it for a few days and you're not seeing anything. Then it's best to get off of that sooner than later and not hold on to it, because you don't know if it's helping or not. If it's helping, you should know. Otherwise, it may not be helping enough to offset the risks that are associated with every medication. Medications also obviously come with side effects like we were just talking about. And it's important to pay attention to anything that changes during that time, because although we have, what we consider to be known side effects, every person is different. And there might be something that you experience that is less commonly known. So if something changes and it's uncomfortable for you, it's important to let your provider know so that you and them can decide on how to problem solve with that medication, whether it's reducing the dose or getting you off of it, or if that will pass in a couple of days, typically, depending on the medication. It's also really important to make sure that whoever is prescribing for you knows what other medications that you're on so that they can check for drug interactions. It's also really important to have your provider know if you use any other drugs, whether legal or illegal, alcohol, herbal products, supplements, etc., because they all have the potential to cause drug interactions. And at the very least, using just one pharmacy and letting the pharmacy know if there's anything else that you take that's not prescribed so that they can let you know if there's an interaction, because some of them can be very serious. All right, so safety. It's always important for you as the patient taking the medication to know what you're taking it for and when to take it, so that you can see, is it helping with what you're trying to take it for, right? And if you're taking something in the morning, but it makes you sleepy, is it possible for you to safely change it to nighttime, which again needs to be gone over with your prescriber. But that's also why it's important to know. Or let's say somebody is on, not a pain medication, but a medication that is frequently called a water pill or a diuretic that makes you urinate a lot to help with blood pressure. You don't want to take that in the evening, right? Because you'll be up all night using the bathroom. So it's important to take that one during the day. There are pain medications that have times of the day that is more beneficial for you to take them at. So it's, again, important to know when, where, why, how, all of the questions. Follow the instructions, right? Prescribers have a reason for why they are having you take it a certain way. And to deviate from that could be potentially dangerous or could cause you to not get the benefit out of the medication that you could have, and etc. So always, if you're not clear on something, then it's always important to call your prescriber and ask them. Don't share medications, right? Because you don't know that friend or that family member, what chronic illnesses they have, what other medications they're on. So what's safe for you might be really dangerous for them. So no sharing, and keeping all of your providers informed of the medications that you use. Again, really important for safety. And be honest about other substances that you use. first and foremost, we're here to help keep you safe, right? And if we don't know about it, we can't treat you in the safest way possible. So the other thing that's important are pharmacies are run by humans, right? And humans have the potential to make mistakes. So generic options versus brand name option medications may look different. So it's always important to double check with the pharmacist, because it also could just be the wrong medication in general. So never assume that if you get a medication that looks different from what it has in previous months, that it is just a different manufacturer. It could be the wrong medication. So always worth double checking. Don't cut any of your medications in half unless your prescriber or the pharmacist tells you that it's safe. Some medications, this can really be dangerous, as it can break up their slow release mechanisms that they have and give you a whole huge dose all at one time. Or another thing that can happen is maybe it's not intended to dissolve in the stomach, and so it has a protective coating on it to help it get through the acid. And if you cut it in half, it breaks that up and the medication is completely destroyed in your stomach and doesn't get lower down into the intestines where it needs to be absorbed. So don't cut things in half unless you have been informed that it's safe to, or you've asked and been told that it's safe to. It's always important to lock your medications up, right? To keep others safe, but also to keep them from being stolen. It's really important, especially with the controlled medications such as opioids, benzodiazepines, that sort of thing. And I think it's always important, unfortunately, in this day and age, not to tell other people that maybe aren't your partner or something like that, that you're taking opioids if you are taking opioids. Unfortunately, this can put a target on your back and can create problems that you don't need to have in your life. And then proper disposal. So please don't flush medications down the toilet. Take them to, there's a lot more what's called medication take back boxes available in the community, depending on where you live. At several pharmacies tend to have them. They're at police departments, wherever those are at. They're not monitored, so you can go up and just dump them into the box, kind of like when you return a movie or when you mail a package, how you just open up the box, stick something in and close it, and then it's going down and in there. If you need to do it at home, then it's always good to mix a medication with, say, used coffee grounds or used kitty litter or something like that to deter others from utilizing your medication. But if you don't know where, a local take back box is, you can ask your pharmacist or pharmacy, and they will know where all of them are. And some even have little packages within their pharmacy that they can give to you, and they can dispose of them right there. Internet pharmacies. So I'm not going to spend a lot of time on this, but this is a label that you want to use for it. The VIPS label. If it doesn't have that, don't buy your medications from that company. All right. So these are some older graphs that are just showing unintentional medication overdoses using medications. So as you can see, the rates are increasing, and opioids are a bigger drive than cocaine and heroin. And what studies also show is it's not people who are new to opioids that are having the accidental overdoses. It's actually patients and people who have been on them for a long period of time. One of the thoughts with this is that there unfortunately might be a false sense of security that you've safely been on them for a long period of time. And so you're safe to, you know your limits. But let's say you have your opioid medication that you take every day, and then you come down with a cold and you're given a cough syrup that might be sedating, or maybe you take your medications and a friend comes over and you decide to have a couple glasses of wine. Things like this that are changes in your routine are enough to tip the scales that can cause an unfortunate event. Again, these are accidental overdoses, not intentional. And it's usually caused by something out of the norm coming in and making you more sensitive to the medications in some way. So just a note of caution with these. And again, these are just showing some graphs about, what the demographics look like for when this is happening. So now we'll go through class by class through the medications. And before we do that, one note that I want to make is it's unfortunately a common thought that the reason why opioids are being de-emphasized in this day and age is solely because of these accidental overdoses or because of addiction related issues. And although those are serious events, the science is actually showing us that opioids, when used chronically or for long periods of time and consistently, actually cause changes in our brain where even though they help with pain in the moment, they're actually making you more sensitive to pain and doing something called causing neuroinflammation or inflammation within your nervous system that is thereby increasing pain in the background. And so we're really trying to get away from using opioid medications because we fully believe that we should be using medications for you that aren't worsening things for you. So when you think 10 or 20 years down the road, we want you to be in a better place and not in a worse place because of a medication, right? So starting out with Tylenol or acetaminophen, so a common over-the-counter medication, right? That can block some of the pain signals and reduce pain overall. So important things to know about this is the label suggests 3,000 to 4,000 milligrams daily as a maximum. I would say if you're young and healthy and using this on a routine basis, then you shouldn't exceed 3,000 milligrams per day. And keep in mind, this is from all products because Tylenol or acetaminophen can be found in other things such as codeine products or oxycodone or hydrocodone products, and in cough and cold products, arthritis products, right? So you want to make sure that you know where all of the acetaminophen is coming from and not to exceed 3,000 milligrams per day. If you're using it for, you twisted your ankle and you want to use 4,000 milligrams for a few days, that's fine, but long-term, don't exceed 3,000 milligrams per day. And then if you're older, I would say 65 and older, or if you have, a history of anything that is associated with your liver, such as hepatitis or fatty liver disease or anything like that, then 2,000 milligrams a day should be your max. And if you're actively drinking alcohol or if you have severe liver impairment, then you should avoid acetaminophen altogether. NSAIDs, which is also, known as anti-inflammatories, we'll talk more about on the next slide. And then topicals. So topical creams or gels that can include NSAIDs, lidocaine, capsaicin, amitriptyline, baclofen, ketamine. So some of these products are over the counter, right? You can get lidocaine patches or lidocaine cream over the counter. You can use things like Icy Hot over the counter. And then there are options for some prescription, although it just went over the counter, diclofenac, which is a topical anti-inflammatory. And then your prescriber can do compounded creams that can include several prescription-based options all put into a cream. So say you don't tolerate the side effects of taking something orally, sometimes it can be effective when it is compounded into a cream that you rub onto the area instead. The only downside about this is insurance companies don't tend to pay for topical creams, so it's an out-of-the-pocket expense, but they can be helpful. So NSAIDs. So the most common ones that you probably know about are ibuprofen, naproxen, aspirin. There's several prescription-based ones like meloxicam, Celebrex, diclofenac, etc. These can be really helpful in reducing inflammation and helping with lots of different types of pain. Some things you have to be really careful about with these, though, is they can be really upsetting to the stomach or cause stomach ulcers that can then turn into stomach or intestinal bleeds. So be really careful with this. Food can sometimes help, but really we can't predict when this is going to happen. Studies show that in one person, it can happen after a single dose, and in another person, they could be on it every day for years and then all of a sudden develop a stomach ulcer. So the rule with this is to use it for a short time, if possible, and to use the lowest effective dose because that reduces the risk for side effects. Also, anti-inflammatories or NSAIDs are commonly known to increased risk for cardiovascular events such as a heart attack or a stroke. So if you have a history of either one of these, you should avoid NSAIDs at all times. Or if you're at high risk for this, you should be really careful. They can also increase blood pressure. So if you struggle with hypertension, be really cautious with this. And they can also increase what we call peripheral edema, or swollen ankles, or puffy fingers, those sorts of things. So heart failure is another one that you really want to avoid anti-inflammatories because it can make you retain water. And then if you have kidney problems, anti-inflammatories or NSAIDs can be really hard on the kidneys, especially if you're not well hydrated. So let's say you get the flu and you're having a hard time keeping anything down. You want to take a break from your anti-inflammatory so that it's not hard on your kidneys. If you're well hydrated and you don't have kidney issues, then it should be a minimal problem, but still something that we definitely need to run lab work on to monitor your kidneys if you're on it for extended periods of time. So some other classes that we'll be going over include the antidepressants, anticonvulsants, antispasmodics, muscle relaxers, and opioids. And please, if you have any questions that come up throughout this presentation, then just jot them down in the moment so you don't forget about them. And then anytime you have a follow-up with us or one of your other providers, feel free to ask them and they can answer it for you. So starting with antidepressants. So this group of medications, with two classes in particular within the antidepressants, are considered first line medications to help with pain. So initially obviously treated to help with depression or other mood disorders. And the only ones that work for pain are the ones that work on both serotonin and norepinephrine. But if they don't work on norepinephrine, they're unlikely to help directly with pain. And so listed below are the tricyclic antidepressants, which amitriptyline and nortriptyline are the ones I use most commonly in my practice. And then the SNRIs, so duloxetine and venlafaxine are the most common ones again. Milnacipran can be helpful. It's more expensive currently because it's newer. So amitriptyline and nortriptyline are two that can help with sleep. They can make you sleepy, so you take them once a day at bedtime. And they can be really effective for helping with, say, neck pain or back pain or nerve pain. So neuropathic pain or pain that shoots down your legs or down your arms, or let's say nerve pain in your feet from diabetes or from a back injury. These can be helpful. The duloxetine or venlafaxine, again, you still take that once a day. They don't necessarily make you sleepy, so you can usually take them in the morning or at night, depending on how you respond to them. And they can also help with several different types of pain, including, let's say, arthritis pain or back pain, nerve pain, musculoskeletal pain. So anyways, several different indications for each one, and they can be very helpful as long as you tolerate them and notice that they're helping you. Because again, we want to always weigh, is it truly helping you, or are you hoping it is, but not really seeing a difference? And then we need to have a conversation about whether or not to continue it. Anticonvulsants. So this is a group of medications. As you see down below, gabapentin and pregabalin are our most common ones. Lamotrigine and topiramate are probably the next group that's more common. And these were all developed to be anti-seizure medications, right? But with gabapentin and pregabalin in general, we discovered that they weren't very helpful for treating seizures, but they did have a really good effect with lessening nerve pain. And so these are two more first-line agents that we commonly use for different types of pain, right? And so some things to keep in mind with these ones if you get started on them is typically starting lower and slower helps you tolerate them easier and then build up as your tolerance to any potential side effects builds up. If you're on too high of a dose of these or they were started too aggressively, you can experience things like feeling sleepy, having your thinking feel slowed down or forget words more commonly. They can also affect your balance or your vision, making your vision a little blurry. But again, if we either reduce your dose or slow the dose increases down, a lot of times these can be helped so that you tolerate it better. The average person in studies needs to be on 1,800 to 2,400 milligrams per day of gabapentin to find benefit. Although I do have some patients that only need to be on, say, 300 milligrams at bedtime, and this works well for them. So everybody's different, but again, the average person needs to get to between 1,800 and 2,400 milligrams to have effectiveness. And pregabalin, is the average person is typically on 75 to 150 milligrams 2 or 3 times a day. But again, everybody is different and some people require much less. The side effects are similar between gabapentin and pregabalin, although some studies show that pregabalin is more frequently better tolerated and more effective. Although I will say within my practice, I see it both ways, where for one person, gabapentin is better tolerated and more effective and vice versa. Weight gain is something to monitor if you get started on either one of these medications. If your weight starts going up, we need to know about it sooner than later, because unless we reduce the dose or stop it altogether, the weight gain may not stop. All right. So again, doesn't happen with everybody, but something I want you to monitor if you get started on one of these so that we catch it before it becomes a problem. But overall, these medications can be very beneficial depending on what you have going on. Muscle relaxants. So with these, I want you to be very clear that muscle relaxers do not actually act on your muscles. They have more of a sedative or an anti-anxiety type of effect. The guidelines recommend not using them longer than 3 weeks at a time, although I frequently see people placed on these chronically or for long-term use. But then we're losing a tool out of our toolbox to help when you have a flare-up in pain, right? Because you've developed a tolerance with these and we no longer can use these to help settle down a pain flare. Also, none of these medications were designed to be muscle relaxants, and we don't truly know how they work. So carisoprodol or Soma is not recommended at all. It's actually more of a tranquilizer and it's highly addictive. So we don't even use this in our practice. Cyclobenzaprine, methocarbamol, metaxalone. These, like I said, can be used for short periods of time, but typically should not be used long term. They should be more so used for a flare for a few days to settle it down and then stop taking them again. Benzodiazepines can sometimes be used, but they would be last line and only for a short period of time because you develop a tolerance to them. They can be really dangerous when mixed with other medications, and they have a highly addictive profile also. Another thing that I like to use for people is magnesium supplements. So a lot of us Americans are deficient in magnesium just due to the way that agricultural practices are these days, and soil deficiencies and a lot of different things. And so sometimes a magnesium supplement can be helpful. You need to discuss this with your provider though, because magnesium isn't the best choice for everybody. But if it's going to be, if you're taking the right dose, you should notice a benefit within a couple of weeks. And magnesium is also known to help with sleep and muscle function and headaches, and it can also be helpful for depression. So definitely speak to your provider about that. If muscle spasms or muscle cramping, difficulty sleeping, headaches, that sort of thing are an issue for you, because magnesium might be something that helps with several things all at one time and is a natural thing that our body is actually deficient in and needs. But again, it's cleared out by the kidneys. So if you don't have good kidney function, you want to avoid it. And then there might be some other reasons why it might not be the best option for you. So definitely check with whoever your provider or prescriber is. Antispasmodics. So these are medications, tizanidine and baclofen, that are more associated with helping if you've had a spinal cord or a brain injury, because they're treating spasticity, which is muscle jerking, rather than, kind of some contractions of muscles. So again, if you have a brain injury or a spinal cord injury, you may need to use chronically. But some patients will not tolerate some of the muscle relaxers and might be placed on baclofen or tizanidine for muscle spasms or muscle cramps. So the same rules apply, that you still want to use them for a very short period of time, because again, we don't know exactly how they work. And the best thing to do is use them for as short a time as possible, unless you have the spinal cord or brain injury. And then that changes things, because they might become a chronic part of your treatment plan. And something to be said about muscle relaxers and antispasmodics is they can make you drowsy. They can cause hypotension or a decreased blood pressure that can make you lightheaded if you go from sitting to standing. So they do have a potential for increasing fall risk. So we especially want to be careful with anybody 65 and older, or for anybody else who is on opioids or might have increased fall risk for other reasons. Mixing these with opioids can increase your risk for having respiratory depression or slowing your breathing down and leading to an accidental overdose. So again, something to be really careful about. Opioids is our next topic. All right, so these are some of the short-acting ones. So hydrocodone, codeine, hydromorphone, oxycodone, morphine, and oxymorphone, which we don't use very often. So as I mentioned before, these do have their places in helping with acute pain situations and in some chronic pain situations. But as a whole, for chronic pain, we really want to do our best to de-emphasize the use of opioids, because as I mentioned earlier, we don't want to have you on something long-term that is also at the same time likely making you more sensitive and have increased pain later on. We want to really focus on other therapies and treatment plans that are helping you get better and not keeping you as somebody struggling with pain, right? So also something to be really careful about is if you have any conditions like with your lungs, such as COPD, or if you have sleep apnea, these conditions can really increase your risk of having some really dangerous side effects when using opioids. And then as you can see here, there's also extended release versions. And again, we really de-emphasize the use of extended release versions, especially because the risk of an accidental overdose is more so with extended release, especially if you have sleep apnea. And something really important with the fentanyl patch down here, about 3/4 of the way down, is that if you have one of those, you really need to avoid heating pads or wearing them in a hot tub or areas where it's going to really heat up your body, or if you have a fever, because it causes a lot more medication to release. and it can cause an overdose. The other important thing to know here, as we mentioned way back at the beginning of this presentation, you don't want to cut any extended release medication in half, as that breaks up its release mechanism and can give you the whole big dose that you're supposed to be getting over, say, an 8 to 12 hour period, or even sometimes 24 hours, like with the new hydrocodone extended release, all within, say, 30 minutes, which could potentially be fatal. So don't cut extended release tablets in half, please, or patches for that matter. Tramadol. So this is still considered to be an opioid, but it's maybe in a false way been thought to be a more safe version of opioids. And again, I said false, right? So tramadol, or its brand name is Ultram, it works in two different ways. It works as a weak opioid, and it also has some serotonin and norepinephrine effects, which, if you remember, in the antidepressant category with the duloxetine and the amitriptyline and nortriptyline, those worked by acting on norepinephrine. And so this kind of has a mixture of how it can help with pain. So you don't want to go over 400 milligrams a day, because that can increase your risk for seizures, especially if you have a history of seizures. You really need to be careful with this medication. You know, it's thought that it might have a lower risk for addiction, withdrawal, and respiratory depression, but there are also studies that show when this is being used for indications such as osteoarthritis, it actually increases your risk by quite a bit for all-cause mortality, which essentially means that it increases your risk from dying from any cause just by being on this medication. So again, it's not one to be taken lightly, but it might have some potential benefit over regular opioids, but still overall should be treated like an opioid and used very cautiously. Opioid side effects. So constipation is the one side effect that you don't develop a tolerance to, right? The whole time that you're on opioids, it's going to slow down your bowels and cause constipation. So this is something that needs to be counteracted, and the goal should be to have a bowel movement every day with the use of things like Miralax or Docusate Senna, or magnesium can sometimes be helpful. Eating a high fiber diet, but not supplementing with fiber. Eating a healthy anti-inflammatory diet, right, to keep things moving, is really important. All opioids can cause difficulties with respiratory, right? We already talked about sleep apnea, but opioids can actually be the cause of central sleep apnea, versus with obstructive sleep apnea, they can worsen it or increase your events of stopping your breathing while you're sleeping. They can reduce your reaction time, which could potentially lead to a DUI if you're driving while on one of these. They have a lot of changes that they have throughout the body, such as reducing your testosterone, which can lead to erectile dysfunction, right? But it can also lead to depression with being on them for a long time. They decrease your immune response system, so you can be more susceptible to getting things such as pneumonia. And as we've talked about throughout this, they can cause something called hyperalgesia, which is a phenomenon where they're actually increasing pain rather than decreasing pain. Even though it feels like they're still helping to reduce pain in the moment with each dose, overall, they're causing your pain to increase in the background. They can cause mood alteration, which I mentioned earlier with depression. They can make PTSD symptoms worse, such as worsening your need to want to isolate, as well as other things. And then obviously they have the addiction potential and the risk for substance abuse. So opioid-induced hyperalgesia, which we mentioned earlier. This can happen in a lot of people where it causes pain to worsen rather than to get better. And it's thought to do this by, when you're on opioids, the body or the brain can create extra receptors, right? And then become more sensitive to the pain. There's also, we don't know exactly how it happens, but it can happen with pathways in the spinal cord. And I'm not going to go into huge depth on it, but just know that this is a possibility. And so for many patients who get completely off opioids and stay off for a couple of months, they may find that they have a lot less pain and feel better, and that they at least don't have more pain than they did when they were on opioids. I find this frequently when we're tapering patients, that the first week of the reduced dose, they might have a small bump up in pain because those extra receptors are exposed. But then the pain settles back down to what it was when it was on the previous higher dose, and we just keep bumping that down. And then patients find that they have increased motivation to participate in life, and they are able to think more clearly, feel more like themselves. They may have their sleep apnea go completely away. So it can be really beneficial, although I definitely understand that it can be scary to think about that when you're on a certain dose of opioids and you're already struggling with managing your pain. The idea of coming off of opioids is oftentimes really scary, but I hope you find encouragement in this, that if you trust the process and go down slowly, that you might actually find out that you feel either the same or a lot better, but typically not worse if you come off of opioids in the right way. So now Trexone does the opposite of what opioids do. It's actually what we call an opiate antagonist, and it blocks opioid receptors in the nervous system. It can cause withdrawal if you're on opioids, but if you've tapered off or you've never been on them, then it doesn't affect that piece of it. What we do know, we don't know exactly how it works, but what we do know is that it might be having an anti-inflammatory effect on the nervous system, amongst other mechanisms. And there's actually really good research on the effectiveness of this for fibromyalgia pain, but there's also growing research on treating CRPS, or complex regional pain syndrome, as well as a lot of other different pain topics, such as lower back pain in general. So I think this is an up and coming medication that is likely going to be used more. What I will say about this medication is that I would say that overall it works for likely a small percentage of people, but when it does work, it works incredibly well. So anyways, and also you need to be on it for at least a couple of months before being able to say whether it's helping or not, because it's doing a lot of background work that has to build up. So addiction, I always like to clarify that dependence and addiction are very different from each other, right? A lot of people throw around, if they've been on opioids a long time, that they are addicted to them. And the fact is that oftentimes people are actually just, excuse me, bless me. If somebody's been on opioids for a long time, it's likely that their body is just dependent on them, right? Similar to somebody who drinks coffee every day. If you go without coffee, you tend to get a headache or feel really irritable because your body is dependent on it, right? It's gotten used to it. And it's saying, hey, I think you forgot our morning cup of coffee this morning. And so I'm going to give you these really irritating side effects to it, right? And that's what can happen with being on opioids for a while, or antidepressants, or, several different classes of medications. Your body can become used to them, and it can give you uncomfortable symptoms if you stop it. Versus addiction is completely different. And we'll go over some more on the next slide, I believe. But yeah, so analgesia is another thing. And opioids can help with both, right? Opioids can help with physical pain, right? But they can also help with emotional pain. And it can sometimes be hard to tell the difference between the two because pain is complicated. If you've learned nothing else through this whole pain education, it's that pain is complicated, right? And it's contributed to by lots of different things. But what we really want to be careful of is when we're using opioids to handle or to help with pain, we want to be making sure that we're mostly focusing on the physical and using other tools to help with emotional pain. We covered physiological dependence, and we've talked about withdrawal symptoms, right? You're freeing up receptors and other things in your body are needing to kick into gear that have been suppressed or emphasized with the use of opioids. So withdrawal symptoms can be runny nose, really watery eyes, yawning a lot. It can be body aches. It can be, diarrhea, increased anxiety, increased pain. But if you are tapering on an opioid, if you go slow enough, then you shouldn't experience withdrawal symptoms, typically around 10%. And then it depends on how quickly, depends on how long you've been on them. But again, this needs to be worked out with your prescriber. Misuse. So something to be really careful about, and what will result in somebody stopping prescribing is if you take more than you're prescribed, right? Because then you're essentially self-prescribing and saying that you know more than the prescriber, which is actually illegal to do, and kind of leads to the provider having to stop prescribing. Or sharing your medication. It can be really tempting to help mom or sister out if they're having a hard time, but this can be a really big problem because you don't know everything that they have going on and how safe it is. So only using your own. And then abuse. Abuse is where you're taking things for fun, right? Rather than to help with medical conditions, such as helping you just to be able to function in your day easier, right? So just some definitions. So addiction, the 4 C's, right? Impaired control over drug use, compulsive use, continued use despite harm, such as you keep using it even though you got fired from your job because of it, or you had a divorce happen because of it. And then craving. So those are the 4 C's, and I think that really helps to delineate what is dependence versus what is addiction. And then how to prevent addiction. If at all possible, don't use them at all, which is the best way to go about it. Tell your healthcare provider about any personal or family history of substance abuse or addiction, because this increases your risk of having a challenge with addiction. Taking your medicine exactly as it is prescribed. And if you find that you want to take more medication than prescribed, ask yourself, what kind of pain are you trying to reduce? Is it physical, emotional, social, etc.? And again, we really want to focus on helping with the physical pain to increase your function and your ability to live your life. And we really need to be using other tools to help with other types of pain. All right. And with that, we have reached the end. I hope this has been helpful. And like I said, feel free to schedule a follow-up with me or bring your questions to your provider. And all of us are happy to help you out with any next steps that we can. Thank you so much.